1, 2, 3, so I guess we'll go 1, 2, 3. This way we'll know the order.
Sure.
Hello, hello, hello. Hello, everybody. I want to thank you for coming out tonight and not getting your hands dirty, gardening, being in the bushes and getting your landscaping done, which I know everybody did, when it's sunny like this. But when Buffalo, when the sun is out and the weather gets warm, we all appreciate it here. I just want to welcome everybody. My name is Joe Curatolo. I'm president of Georgetown Capital Group. There's some of you that I've never met, many of you that I've known for many, many years. So I want to thank you for coming in to our May 2018 speaker series, The Future of Medical Care, You and Your Doctor. And tonight we've got 3 great panelists that are going to get up here and talk about a variety of things that will help you understand what's going on with medicine so you can become your own advocate, because it's important. We all want to be healthy and we want to be around a long time. The objective of the speaker series that we've done now for almost 15 years is always to deliver experts on something that has nothing to do with investments. Because you can always watch CNBC, you can always watch the different shows that have their own experts on investments, but more importantly, you can call Georgetown Capital and get the investment advice just from us. So what we try and do is we try and throw some humor into these evenings, try and give good information that you can take away that will affect your lives today or maybe a year or 2 from now. On a business note, and this is the 3rd time I'm saying this, the 3rd time that we've met, on a business note, when it comes to the stock market, I want to tell you, everybody here has more money than they had a year ago, and that's why we're all together. We are videoing tonight, and that's for the people that can't attend tonight. We're going to be putting it on our website probably later in the week or early next week if you want to watch it or tell all their friends about it. That's good. As I entered tonight, I noticed a lot of people that I've known for many years. Ann and Ed Glassman have been clients for 27 years. Bob Ruderman, who I remember when his son was going to St. Joe's, we figured out paying for that, and then paying for college, and then they got married. Now he's got kids. So we've known each other for many, many years, and because of that, I wanted to, talk a little bit about my family, the Georgetown Capital family, the girls and the guys and the staff at Georgetown, that all have their own lives. We know you and a lot about you, but you should know something about us. Like Steve Zontek, who couldn't be here tonight because his father-in-law died. Steve's been working with me for 37 years. Ron Migliori, I remember when I recruited Ron 37 years ago from St. Bonnie when he got his master's degree. And Ron's going to have his daughter, Liz, is getting married the end of this year in Cape Cod. So if you're a client of Ron's, ask him how his daughter's doing, things like that. Ed Harif I've worked with Ed for 35 years, and his son is getting married next month or so. My brother Mike, who I've known all my life, obviously, but Mike's daughter Grace is graduating in a week from John Carroll in Cleveland. These are the people, these are some of our families and what we do, and I think it's important because we're family. And the money is money, and we know what our job is, but we also want to help each other out. Stacy, who this week celebrates 20 years with me at Georgetown, later this month she's going to be recognized for an award having 35 years with the Girl Scouts, and I think scouting is a great thing. It teaches leadership skills, it teaches interaction skills. Melissa, if you want to talk about a different kind of life, Melissa's home life, Melissa has a hobby farm. She's got horse, pigs, chickens, goats, everything. I mean, that's interesting. That's something that you don't get to hear much about. Kelly Strausser and her husband Ron have got 2 great kids, and they're probably always be rehabbing a house that's built in the 1800s. Judy, who's the voice of Georgetown Capital, her and her boyfriend Chuck, they're rehabbing a house that'll again take forever because it's built over 100 years ago, and she just had her 4th grandchild. And then Christine, who's been with us about a year, she's buying a house in a couple of weeks. She's getting married later this summer. Julie, whose daughter is graduated a couple of days ago from Nazareth. Now, here's a good story. Her daughter graduated over the weekend. She's starting a job today. Now, that's great. That's great news when you get a kid that can get right out of school. So these are our family members and what we do. And then there's Kathy Curatola, my wife. Kathy is what I call the Chief Cultural Officer of Georgetown Capital Group. She makes sure the events go great, everybody's got a great atmosphere, and because of that, we get this award again for the 8th year in a row that Georgetown Capital is one of the best places to work for in Buffalo. So I want to give my round of applause to Kathy and everybody else. They're the family that makes me enthusiastic and drives our great customer service. In case people didn't know about one of my hobbies, it's the Ride for Roswell. It's coming up in another month. Last year, our team, Kids Just Want to Have Fun, raised over $150,000 for a one-day charity event. This year, we hope to do it again. If you know anybody that rides in the Ride for Roswell or wants to volunteer, feel free to see me because it's a passion of mine. I've ridden in most of the rides for the last 22 years. In the last several years, we've raised, just in our team, well over $600,000. So again, these are the things that drive me, that drive Ron Migliori or Stacy or Kathy, just, because we like what we do. To us, it's not work, it's a lifestyle. But with that said, we're here today to talk about the future of medicine. Tonight we've got 3 great guest speakers here. We got Dr. David Hughes, who's the Chief Medical Officer at Kaleida Health, Alan Norman, who has been my primary physician for probably well over 15 years, and I think was the first physician's office that was way advanced on the technology side with laptops and things like that. He's a primary physician. And Dr. David Rice, who, again, he's my dentist, Kathy's dentist. He is cutting edge, speaks around the country to thousands of people on what's going on, whether it's in dentistry or the medical field. I'm just going to stop at that point and ask David Hughes to come up and start with, what's going on in his field. David is Chief Medical Officer at Kaleida. He was an emergency room surgeon, so he was there when the lightning bolts were striking, an emergency room action, and he's got a great view of what's going on from big picture on medicine.
Thanks, Joe. Good evening, and thank you for that warm welcome. As Joe said, my name is David Hughes. I'm the Chief Medical Officer at Kaleida Health. I assume everybody in the room is familiar with Kaleida Health? Yes? Has anybody had the opportunity in the room to see the medical campus or to visit the medical campus, whether it be the medical school or the children's hospital? A few, not many. I would invite everyone in this room to come down and see what's going on down on the medical campus. It is spectacular. And it's spectacular for a variety of reasons, and I'm going to give you a little bit of a story to start in how medicine is evolving and what the future of medicine will look like. Last week I was in the Gates Vascular Institute, which is down on the medical campus, connected to the old Buffalo General, and I was in what's called our catheter lab suite. And in that suite, we have 16 different catheter rooms where we do procedures. And around this, it's a square kind of building, and around the outside of the building are all these labs, 16 of them. And we have neurosurgeons working on one side, we have electrophysiologists working on one side, we have cardiac surgeons working on one side, and we have invasive cardiologists working on another side, all around this kind of square area where they all convene in the middle, and they have what we call collisions, in essence. Collisions in a good way, where they can innovate, where they can come up with new technologies, new treatments for people that are ill or are sick. And last week when I went up there, I typically when I go up there, I go up there a lot, and I see a lot of really cool things going on. But I saw a procedure last week that was being done in that Gates Vascular Institute. It was a 27-year-old woman who had what's called an AV malformation in her brain that needed to be fixed because they tend to bleed and they can be fatal, quite frankly. So we've got a neurosurgeon in the room that's got to put a catheter from the wrist up into the brain and close off this AV malformation. In order to close off the AV malformation, he can't do it while blood is flowing across that AV malformation. So he's got a cardiologist in the room that threads a catheter to the heart and then induces ventricular tachycardia. Basically causes the heart to stop for a minute. So there's no blood flow across that AV malformation. The neurosurgeon goes in and coils the AV malformation, and then they start the heart again. In a 27-year-old woman who walks out of there the next day completely healthy, without a risk of having a stroke from this AV malformation. So you've got neurosurgeons using catheters, you've got cardiologists that are in there involved, you've got anesthesia, and you've got a beehive of activity around taking care of patients with very, very complex medical problems. That particular case was being viewed by 5,000 physicians across the world at that same time, live. That's what we're doing at Gates Vascular Institute downtown in downtown Buffalo, which is impressive what's happening down there. Really, really neat stuff. If you ever get a chance, I'm happy to invite you down and take a look at the campus. You couple that with the medical school that just opened in January. The facility of the medical school is spectacular, and the learning environment is state of the art. You can't get any better than what's there. So we have the facilities, we have the physicians and the people that are performing some of the most innovative care anywhere in the world, and the know-how and now the facilities to support all of that care. It's all happening in our city as we speak. It's really incredible stuff. So I wanted to start there just with a kind of a where we are from the future of medicine. The future of medicine is now. A couple other things I want to hit on, because medicine is getting really, really complex and complicated, in particular for patients. And as many of you know, if you've been in and out of the healthcare system, whether it be at your primary care doctor's office, whether it be going to the pharmacy to pick up a prescription drug, whether it be having a hospitalization or a surgery, it gets very, very complicated. What has happened at Kaleida Health over the past 3 to 4 years, and I started at Kaleida Health back in 2013 when Jim Caskey was the CEO, we started looking at our region in Western New York and thinking about how do we take the healthcare system and bring it together. And part of doing that is the recognition that to bring things together, you have to have kind of a stake, or you have to have a position in each of the different aspects of care delivery. So starting 4 years ago, Kaleida Health started partnering with community hospitals such as Olean General down in the southern tier, Lakeshore, Brooks, more recently Lockport Niagara Hospital, looking at those hospitals, trying to figure out how can we provide care in those communities that's appropriate, but then when they need higher level of care, how do we bring those folks to a center of excellence like the GVI, or like our orthopedic center, or like our cardiac services. So we started to aggregate kind of what we call the continuum of care as it's delivered from children, from babies, all the way up through death and dying, quite frankly. And we started to aggregate those resources. And we started to make affiliations with hospitals and outlying communities. We have skilled nursing facilities, we have home care, we have lab, we have radiology services, we have urgent care services, we have primary care practices and specialty practices. So we started to look at the environment of how healthcare is delivered. We started to figure out how we could play a role in each one of those settings, because the next 3 years and the future of medicine is about integrating those. And I'm sure Dr. Norman will talk a little bit about what his experience is in a primary care practice and how you integrate care across the entire community. Huge amount of IT involved in that, so information technology, and how you ultimately connect care providers and sites of care, so that ideally, the ideal scenario would be as a patient, you would walk in to a primary care doctor's office. If you were referred to an emergency department or to have an x-ray or to have lab work, you would never have to show your insurance card again. You wouldn't have to fill out the demographics. You'd have all of that would be available to the provider or the service, ancillary services, through the computer, right? That would be the ideal scenario. There are not many places across the United States right now that can do that. But that's what the goal is of healthcare going forward, is how do we integrate our delivery systems so that care is continuous and you don't lose things along the way, and it's not burdensome and it's easy to follow. So that's the direction that Kaleida, in particular, over the next 3-4 years is going. It revolves around significant investments in IT. It revolves around bringing the continuum of care together in a straight line for patients, ultimately. And ultimately, the goal of all of that is to develop and to deliver better quality at the individual patient level, better efficiency so that we're not spending as much, quite frankly, on healthcare, and ultimately a better experience for the patient. So those are the kind of the three tenets that we live by as a health system. The other thing that's driving the healthcare system, in particular around payment, is population health. Has everybody heard the term population health before? Population health is how Medicare, Medicaid, local commercial payers are starting to view how healthcare is delivered. They don't necessarily look at it at the individual level. They look at it across a population. And what they're trying to do is say, if I have 500,000 insured people in my plan as Blue Cross Blue Shield, how do I manage those 500,000 people in a quality way, but also the most efficient way possible? That requires significant, again, IT, information technology. It requires data analytics. It requires a difference in how ultimately insurers will pay for healthcare that's being delivered. It's part of the reason why you'll see, and everybody in this room knows, their co-pays, why your co-pays go up, how you ultimately have your healthcare paid for is going to be much, much different in the future. Buffalo is probably about midstream in this process when you look across the country. But as time goes on, you're going to see less and less individual patient kind of prices, for lack of a better term. You're going to see what's going to happen is you're going to see health systems starting to take risk. They'll become more like the insurer as they deliver that health care. So what it costs, so for instance, I'll give you an example. If you're admitted to Buffalo General Hospital and you're having chest pain, the government, CMS, will pay what's called a DRG, a diagnosis-related group payer for that. So they'll pay one price for that admission for chest pain. If you stay in the hospital 10 days for chest pain, they're going to pay the same price as if you pay for 2 days, as if you stayed for 2 days. So what does that mean? It means the healthcare system really starts to look at how do we become more efficient? How do we look at chest pain in aggregate and say, people that get admitted to the hospital for chest pain on average need to stay in the hospital 2 days. Otherwise, we can't sustain ourselves. It costs us too much money to keep people in the hospital any longer. So that's the pressure you're going to see as patients. You're going to see a lot of pressure on trying to produce care in the right place, whether it be as outpatient. You're going to start to see a lot of pressure on moving procedures, for instance, joint replacements. Just recently this year, CMS came out and said we're going to start paying for joint replacements done in an ambulatory surgery center, which 10 years ago was unheard of. Nobody would even consider replacing a knee in an ambulatory surgery center and you going home afterward. That's happening now, and it's happening in Buffalo at this time. You're going to see more and more of that, trying to push care out into the community and to try to keep people healthier, quite frankly. Part of that payment shift then is just a reform. It's called payment reform or population health. It's how we manage an entire population across our region. Beyond that, I think you're going to see, as we look at healthcare spend, and in the United States we spend about $3 trillion a year on healthcare. If you look at how that's broken down, probably about a third of that is hospital related, a third of that is physician related, and probably 20% of it's pharmaceutical related. That spend in the US is going to have to slow down, obviously, and it's going to have to change where it takes place. Some of that spend is going to be shifted over to the physician and the provider side, and the risk of that spend is going to be shifted over to their side as well. as we continue to move down this path, that burden of being healthy is going to fall more and more on the individuals and the people in this room, quite frankly. You're going to find that the financial impact to yourselves related to healthcare is going to be more and more significant. You're going to be taking on more risk, just like health systems are taking on more risk. The federal government is going to continue to push on co-pays. They're going to continue to push on how much they're spending around medicine. They're going to continue to push on where that care delivery has taken place. And ultimately, I think, in the end, I think we end up as a better country, as a better healthcare delivery system when this whole thing plays out. But it's going to take a lot of pain in the meantime. So this fee-for-service world that we've lived in for as long as anybody can remember, when it changes, it's going to be, and as it changes, it makes a significant impact on individuals and healthcare systems. So I'm going to stop there, and I'm going to let Dr. Norman go ahead and take over. And I think we're going to take questions afterwards, Joe.
Thank you. Just so you know, we didn't coordinate this program before we started, but it seems like he just set me up, and in a good way, so when Joe asked me to do this, he said, I'd just like you to get up and talk to people about what they should expect in a doctor's office and how is it different now and what should they expect in the future. And I said, okay, that's great, I can do that. And as I was thinking about this, I said, well, I really can't do that without going back and telling you what I think medicine was, at least what it was to me as an internal medicine doctor when I started out. So I started out 33 years ago, graduating from our residency here at Millard Fillmore. I started out working full-time ER at night and running a practice during the day. When I started out, there were two major insurers in the Buffalo area. There was Blue Cross Blue Shield and Medicare. And the way the office worked was an initial visit in the office was $50 and a follow-up visit was $25. You came in the office, you saw the doctor, you paid whatever it was. Some of that, and mostly only hospital, was billed to the insurance company. About 2 or 3 years later, the first HMO in the area, Independent Health, started up, and they started actually paying for office visits, which most of the insurers never did. So in 1985, when I started, medicine was a production-based operation. You got paid for what you did. The more patients you saw, the more money you earned. So, sounds like a good deal, right? We go to work, we see more patients, we earn more money. As time went on and the HMOs became more formed, they tried a bunch of different things to limit what medical spending was, because obviously the more you see people, the more money you spend. And their idea was, well, if you see people more, you'll order more tests, you'll order more drugs, we'll pay for more things, so medicine will be more expensive. Sometime in the 90s, Independent Health and Blue Cross Blue Shield both went to a system of payment called capitation. And capitation is based on a monthly payment for members in your practice. So you would have to pick a primary care doctor. The insurance company would know who your primary care doctor was, and they would pay us some fee per member per month. It wasn't a lot, but over the course of the year, they figured out it would cover the cost of one full physical exam and 1 or 2 follow-up visits. And that's how we got paid. Now, there were some things that were still paid for on a fee-for-service basis, surgical procedures, testing, other things, but basically it was capitation. Time moved on, and the docs didn't like that. They stopped the capitation. We went back to fee-for-service. But as this was happening, there were more and more payers coming into the area. So Blue Cross developed their HMO, which was Community Blue. Univera came into the area. And the payers, again, all got together and a few years ago decided that fee-for-service medicine was never going to work because we were spending too much money for medicine in this country. So they figured if they can limit the number of times people went to doctors, then the entire system would save money. Now, that was not done with malice in mind. That was done with the idea of saving money and to force the doctors to be more efficient. So what happened, and I'll skip a bunch of years, but what happened 5 years ago is I joined a group sponsored by Independent Health called the Primary Connection. It's 40 or 45 practices, 220 doctors, and it's a group that is capitated. We're fully capitated, meaning that we only get a certain number of dollars per member per month. There is no more fee for service. We are paid on an incentive basis based on performance. Performance being how well we take care of people and how much money we spend. That started 5 years ago, and we would get our capitation money. At the end of the year, they would look at total number of dollars spent. They would look at parameters that we had to report to them. So in people with high blood pressure, what were their blood pressures? And people with diabetes, what were their sugar numbers? In healthy people, how many of the required tests that they were supposed to have did they have? How many women over the age of 40 had mammograms? How many people over the age of 50 had colonoscopies? Men having their prostate-specific antigen measured. And based on that, they would say, oh, you did a good job, we're going to reward you with this bonus. Or you didn't, so we're really not going to reward you. So that has evolved over the past 5 years, and 2 years ago, Blue Cross Blue Shield's HMO decided to do the same thing. So now for the bulk of people in Western New York, primary care doctors, so family practice, internal medicine, pediatrics, and some OBGYN are not paid fee for service. So when you go to the doctor's office, no matter what you see on a charge or a bill, the doctors aren't getting that money. The doctors get a per member per month stipend. And then we report all of these parameters and measures to the insurers, and that's how we get pay for performance or bonuses. What started this year in Western New York, and it's a pilot program with CMS, Medicare, is they're doing the same thing for Medicare patients. So anyone with Medicare or a Medicare HMO, Encompass 65, Senior Blue, Senior Choice, we are now being monitored by CMS for those same things. How well do we perform? How well do we take care of your blood pressure? How many of those tests that you should have done did you have done? And they pay us on a per member per month basis with some type of incentive at the end. So what does that mean for you? How does that change how we practice? When you go to the doctor's office now and you think you see doctors staring at their computer the whole time you're in the office, yes, they're staring at their computer, but probably they're still listening to you. You know, it took a long time for me to be good at the computer so that I could talk to someone and look at them and still play on my computer and record what I have to record, because it's not what we do, it's what we record that counts for everybody. So, you know, give the docs a break when you're looking at them thinking, oh, yeah, I was in there for 15 minutes and all he did was look at his computer. But really, what they're trying to do is make an assessment in the most comprehensive way of what your medical needs are. Not that you came in for a physical exam, not that you came in because he's checking your blood pressure or your sugar, but what things do you need to have done over the course of a year that should be done, should be scheduled, that he should check. So medicine is going to become much more comprehensive. Each visit will become more comprehensive. The docs will be more interested in making sure everything that should be done is done, not just focusing on your blood pressure or your sugar or that you're supposed to have a physical. Now, the parameters that we have to meet differ with each individual, with each demographic. So based on age, sex, disease burden, what we have to do is different. But and I said, look out here, and I didn't know what age group people were going to be when we came in tonight, but most of you will understand that Medicare is either in your future or in your present. So one of the things that we are mandated to do is something called an annual wellness exam once a year on everyone with Medicare or a Medicare HMO. And that's our Medicare mandate to make sure everything that you were supposed to have done or should have done or parameter you should meet is done. So now we have a nurse who just outreaches to all our patients to make sure they're coming in one time a year for this scheduled exam. So all she does is she outreaches to patients, explains to them why they should come in, what we need to do. There's no charge, but you really should come in. The other thing that we're mandated to do is to meet all these parameters and make sure patients stay healthy. Again, we're not getting paid fee for service to have patients come in the office, only to keep them healthy. So we just hired a care management nurse. And all this care management nurse does is follow up on people who have been in the hospital, follow up on people who have been in the emergency room, call them. We go over their medicine to make sure they're taking the right medicine, to make sure that they have the right follow-up scheduled. If they're supposed to see a specialist, that's coordinated. If they haven't scheduled it, then we schedule it. If they need medicine, we make sure they have it. They don't come in the office. We do this all as an outreach. The other thing that will start probably in the next 90 days as a recommendation, not a mandate yet from CMS, is to have a social worker in the office to coordinate other than medical problems. What are other than medical problems? Well, there's a lot of things that go along with having a disease or having an illness. And it's hard to deal with. And sometimes people don't do what they're supposed to do, don't get their testing done, don't get the medications they need, because they can't psychologically deal with what the illness is. Or they can't financially cope with the burden of all the expensive medications, and they are very expensive. Or they don't get their follow-ups with specialists. So we have a social worker who will outreach to patients to try to work on those problems. If you don't have the resources, how can we get things for you? If you have problems dealing with your illness, what do we need to do to help you do that? Do you need to come in and talk to somebody? Do we need to have you see someone? Do we need to have somebody go out to your house and work through those things with you? Those are the things that we're working at right now to happen within the course of 2018. So medicine has changed a lot from the time that I started, when it was patient comes in, you take care of whatever their problem is, their high blood pressure, their cold, their annual physical, and they leave with no thought to what is the rest of their medical need throughout the course of the year. To what Dr. Hughes said, technology plays a huge part in that. So we've been fully electronic since 2001. So we have a huge database, electronic database of our patients' records. A couple of years ago in this area, there was what's called a RIO, a computer link for hospitals, physicians' offices, called Healthy Link, that allows us now to get information pushed out to people about what our patients are doing. So if I see someone in the office, I can push out my note and my lab results to their cardiologist, to their orthopedic surgeon, to their urologist, and I can get the same things done to me. If someone ends up in the emergency room, I will get a notice saying Mrs. Jones is in the emergency room, and that tells me either wait for the call from the ER or call them to find out why. Mrs. Jones got admitted to the hospital, so now I know that we have to look, find out why is that patient in the hospital, when are they being discharged, and what are their needs after their discharge. Now I work with a hospitalist group, actually 3 hospitalist groups, but this is even faster because everything is real-time and electronic, so I either get notification on my phone, on my computer as I'm seeing someone, and I can talk to the appropriate people in the office and have them do that outreach. So medicine will become more interactive. You'll hear more from the doctor's offices, from the hospitals, from other people associated with doctor's offices, rather than you just calling to say, hey, I need an appointment or I need a prescription refilled. What do we think you should do? What should patients do? What do I have to do as a patient? What is my responsibility? My responsibility as a patient, your responsibility as a patient, is to know what you need or to find out what you need. And we should be telling you that. The doctor should be telling you that. If you have any specific medical problem, what is your problem? What medicines are on? You should know what your medicines are for. You should carry a list with you. You should know what tests you should have on a routine basis. How often should you have a colonoscopy? How often should you have a mammogram or a blood test for your sugar or your prostate? So that when you go into the doctor's office, if that's not ordered, you should say, hey doc, how about my blood test for my sugar? Or I think my colonoscopy was 10 years ago, aren't I due? Because it's really a team effort. I mean, nobody, yeah, I see you laughing out there. I don't want to ask anybody for a colonoscopy, but it's something that you really should do, and they're not bad anymore. The prep is easier and you're out, so it doesn't matter. But you'll find that the invitation to come back to the doctor's office, that reschedule, will be at a much longer interval than you may be used to having it. Or it won't be, oh, I'm going to put you on this medicine, see you back in a week to check your blood pressure. It may be, I'm going to put you on this medicine, you're going to come in and have my nurse check your pressure, and then we'll adjust it as you need it. without an appointment. So I think you're going to see medicine is evolving and changing in many different ways, not because people are too busy, not because docs don't care, but that is the evolution of medicine. And it is much more interactive. It's much more interdependent. And as a doctor, I have to rely on patients to help me out. You have to understand what we're doing so you can do that. So I think you're going to see, especially in Buffalo, Western New York, in the next year or two, as this becomes rolled out and much more broadened, that medicine, as you may think you know it, is going to change. It's changed a lot for me in 30 years. Okay.
Thanks, Alan. Before I hand the mic over to Dave, who I've known for a good number of years, just to piggyback on a couple of other things, to give you an idea, what Dave Hughes was talking about, in surgeries and ambulatory centers. Raise of hands, how many people have had a knee or a hip replaced? Fair amount of people. One of my best friends in December scheduled his knee replacement on a Friday at 7:30 in the morning at Excelsior on Sheridan Drive. So Friday at 7:30 he goes in, knee replacement. By 11:30 he checks into the Wyndham Hotel 4 hours later on Main Street in Williamsville. There's a nurse there for him. He's got a private hotel room, not a hospital room, so you don't hear all that noise and racket and every 10 minutes checking your blood pressure. He orders lunch from Giancarlo's, dinner from Lenova. Physical therapist comes in, to help him out that day. The next day, he's back home by 11 in the morning, Saturday the next day, and the chance of a staph infection basically evaporates because he's not in the hospital. So those are the things that are going on. And one of the reasons why we wanted to have this event tonight was for you to hear, the evolution of medicine and what you can expect. And what Alan Norman just said, it's going to be a two-way street. Your interaction with the doctor, for you to know that you're going to have certain responsibilities. And in his case, he was technologically way out advanced in 2001 with IT. Now he's hiring people to have an outreach to his patients, and it's a give and take. We want you to be healthy. I certainly want you to be healthy. Your family wants you to be healthy. The doctors, everybody wants you to be healthy. But, you have to have skin in the game. And I guess money's going to have something to do with it. And it's also intriguing how Alan was saying how they're incentivized, I don't want to say to have healthier people, but for people to stay healthy longer. So I just wanted to throw that in. And now, Dave, you can come up here. Dave Rice has been our dentist for a long time. I don't think any of these three knew what was going to happen tonight. It's more fun. We have a good time, but it's educational. And he and his wife speak to thousands of people in the medical field every year in America. So, with that, Dave.
Thank you. All right. So, we've talked a lot about, and ironically, Buffalo's a small town, so I'm going to caveat this two ways. First of all, we're very fortunate living in Western New York because our medical care is tremendous. It's a true story. I travel every single week of the year. I'm in lots of different cities in America, and we have tremendous physicians and solid dentists in Western New York, extraordinaire. So thank goodness for everybody in this room, including the three of us up here. But we've been talking a lot about the system side of healthcare today. I want to take us down a slightly different road to the other half of that equation that Joe alluded to, and that's the people side. That's us as people, as providers, and you as people, as patients. So curious, how many of you were born before, or 1945 or earlier? You could admit it. We're in the trust tree. All right, so you are known as the greatest generation of all time, FYI. So beat your chest, be proud. I know. I'm not sure why you're known as the greatest generation, but you are. All right, how many baby boomers? 1945 to 65. Most people in this room. I apologize because I'm going to pick on you a little bit. How many of you have children or grandchildren that are 33 years of age or younger to maybe 21? Good. You'll get this. How many of you like them? All right. Well, this is really very important because I found this shocking a few years ago. I learned this. We're born with really two innate fears. We're born with the fear of falling. So the first thing I did when I walked up here is I learned where the edges were, because I have fallen off a stage once before. And we're born with the fear of loud noises, right? So you've all known your kids, your grandkids, and they know you see them fall over, they get scared, or somebody claps really loud, and they just, they take a step back. And that's mostly important for tonight, because if you guys are anything like I am, you've probably learned some fears over the course of your life, and those fears can sometimes change the way you look at things. And what's really important about that is this. Those of you who have them know. Those babies grow up to be those folks, the millennials. I know. So Joe mentioned that I travel around, I speak to a lot of people. Most of the people I speak to are those folks, right? They're the selfie takers, kind of self-absorbed. They want all of you, we talked about this earlier, to spoon feed them everything. They're tech junkies, and at any given moment when they're supposed to be working, they're probably on what? Instagram, Facebook, Snapchat. You know them, yes? Yeah. Well, that's very important tonight, because whether you've met them personally or whether you've met them in this situation, they are your next physician. Your next PA, your next nurse, your next dentist, your next dental hygienist, it's them. I know, it's a little scary. How's dinner tasting now? That's why I didn't eat. I didn't want to get a sick stomach. Yeah. So here's the reality. When I roam around and I chat with these folks, and I pick on them a lot, because in essence, the coolest thing about them is we look at the world very differently than they do. However, when we get to know them, when we engage them and empower them and educate them, and then they learn all those cool things about you in this room, trust me when I tell you, they are our greatest hope in healthcare. They truly are. They look at things differently. So we get frustrated, and I know you've been one of those people that when you have one of those 20-something to 30-something-year-olds and you feel like they're distracted because this is in their hand all the time, or they don't want to come to work on time, or they want to leave early because 5 o'clock's way too long. And 5 days a week, we talked about that. That's way too many days. Their upside, and what we don't normally see, but I get to see it every week, is this. They don't put a timestamp on anything. Their success, where we measure our success on outcomes and we put a time frame on it, they don't. So it could be 10 o'clock at night tonight, it could be 2 o'clock in the morning on Saturday or Sunday, and they're very, very mission-driven people. If they believe in the mission, if they believe in you as your healthcare provider, trust me when I tell you at 2 a.m., they're sitting in front of their laptop or their phone and they're researching. They're picking up data points like David talked about and Alan talked about. They're working for you all the time. We just don't always see it. So what I want to talk about to you is why. Why are they this way? We joked about this before, right in the back there, because where are baby boomers? Show me your hands again. One more time. I know you're eating, but I'm going to pick any. Okay, so who do you think made them that way? You did. Right. The greatest generation. The grandparents? Well, you had a little something to do with it. Now, there are other things that contributed. So there are world events and time periods that define every single generation. So as a millennial, believe it or not, boomers, you have the most in common with them in this room. So the millennials and the boomers are pretty simpatico with each other because you all lived through similar life events. So back a few years ago, there were 2 towers in New York City that went down at a very critical point in a millennial's growth. and their thought process. It's what makes them so very, very mission driven. But aside from world events like that, it's us. We've taught them to think the way they think, so the things that they fear differently than you and I fear, we've brought to the table. But this is an interesting one. If you look at the average lifespan a millennial spends in a job, so they come to work for myself, or they go to work for David, or they go to work for Alan, it's 3 to 5 years. Is that crazy? You've lived it, right? So how many people keep eating, but how many of you gone to your physician's office, and since the last time you went, there are like 4 new nurses, somebody new's up front, the PA's different, and maybe the doc's different. Same thing at the dentist, right? There's 3 new hygienists, there's a new dentist, I don't know who that person is. Why? Why do they make that shift? They make that shift from a lesson they really learned from parents. So not so much the people in this room. I mean, you all are in a very good position in life, but if you spanned outside these 4 walls, what you'd see was a massive group of baby boomer parents who went to work from 8 in the morning till 6 o'clock at night, 5 days a week, and when overtime became available, they took that overtime. And when somebody asked them to work harder, they worked harder. And then they turned 50 or 55, and what happened? They lost their job. They lost their job. So my brother-in-law is a perfect example. My brother-in-law lives down in Charlotte, North Carolina. I apologize to anyone who may be from Bank of America. But Jason was charged, he had a team of 30-year-olds, and he'd work with them probably from the time they walked out of grad school. So 26, 27 years old. And Jason is in charge of all sorts of international business, but he's also in charge of teaching these kids how to do their job. So for years, 3-4 years, he taught these kids how to be him. And then I think it was like 2011 when Bank of America said, hey, we're going to let 30,000 people go in 2 years. And Jason became expendable. Not because he wasn't excellent at his job, but because he cost more money than that 30-year-old cost. So when Jason went home to my sister and his 3 kids and had a conversation about life, when you and I think that these kids are irresponsible because they're not in Dave's employ anymore, Alan's employ anymore after 3 years, it's not that they're bad people. It's that Jason went home and said, I just worked my tail off for the last 20 years. And at 50, I'm replaceable with a younger, cheaper model. Does that make sense? So the other thing you have to know about millennials is this. They don't look at a career like we do. They have no intention of doing what we do for 30 years or what you did for 30 years. They look in 3 10-year increments. So the dentists who graduated from UB last week will be dentists as we all know them for the next decade. And then after that, they will make a major career shift. And then in 10 more years, they'll make another major career shift. That's really important because a lot of what David's talking about that it's happening on the system side is we're working really hard towards continuity of care. We're trying to de-silo healthcare. We're trying to put physicians and dentists in the same room with each other, physically, virtually, so we can help you all with your healthcare problems. But we've got a gap, right? We have to teach this next generation why that's so valuable because we need to keep these people in place long enough to help those systems work. So here's the other thing that's kind of interesting. Some of you have kids who are really fortunate because you worked really hard and you saved really well and you gave this guy your money and he turned it into way more money. That's awesome. But the average college student rolls out of school with $25,000 in debt. Take a guess what the average physician rolls out of school with. $195,000. And Joe told you I'm the dentist. I'm the token DDS up here. I didn't get the RD. Still, it's over my shoulders. The average dentist graduates with $285,000 in debt. So couple that, right? So now picture Jason comes home and tells his son David, hey, I worked really, really hard all the time. I worked for this career and I put my time in. And at 20 years they said, sayonara. And oh, by the way, I have almost $300,000 in debt. Does that change my mindset? It does, and it's important for you to know as a patient how my head's working, because as a result of that, this is what's happening in dentistry. We're finally catching up to medicine, and that's a good way in many, many ways. So you're no longer going to see the dentist who is yours truly with 2 dental hygienists and 1 person who works up front. You're going to start to see more and more groups. Now, small groups and medium-sized groups are excellent in dentistry. And that's where dentistry and medicine are a little different, because what we do all day long is very procedure-driven, right? It's difficult for me to manage your overall dental care, like we were talking about a few minutes ago, and kind of quarterback things, because I also have to be the guy with that handpiece in my hand that makes that horrible noise in your ear and bad things are happening. So it's a little bit more difficult for us to structure our practice to do that. So in dentistry, having a group of 3, 4, 5, maybe even 7 or 8 dentists is a really, really positive thing for you. It means we can collaborate like these 2 docs were talking about before. We can mastermind about your health. Whether we do it live in our practice or we do it virtually, we can troubleshoot for you and bring specialists in our practice for a more comprehensive health approach for you. So that's a good thing. The danger in dentistry is when that group gets really, really big, because we're not as intelligent as medicine has been. Medicine has done a really, really nice job of maintaining control. So medicine can have these bigger groups like Buffalo Medical and all the ones that I could rattle off their names for you, but they scaled it well to give you excellent medical care. And in dentistry, when we get to be 20 dentists, 10 practices, 20 practices, that gets really, really difficult to do, because the game's change because it's very procedure driven. So I would caution you to understand that small groups to medium-sized groups will deliver excellence to you. Bigger groups doesn't always necessarily mean better, so keep that in the back of your head. Volume is something that medicine manages very, very well, because think about the typical physician team. There's an MD here, and there's nurse practitioners, physician's assistants, nurses, assistants. They have a true, massive clinical team that can help build that care and do a lot of, see a lot. How many patients would you see in a day, Doc?
32, 35.
Yeah, 30 to 30. So if I had to see 35 of you in my day, you guys wouldn't you wouldn't get very good dental care. It'd be very bad. So dentistry is faced with those same challenges, though. We have to increase our volume as these groups grow. It's the only way it's sustainable. And there's a tipping point to how quickly a dentist can perform a procedure, just like how quickly a cardiothoracic surgeon can perform your surgery and give you a great job. The last piece that we're seeing in dentistry on a very regular basis now is we've come full circle. This is a real cool thing. We talked about how medicine wants to de-silo. So now, just like 35 years ago when you come to the dentist, you won't necessarily need to go see 5 different dentists in 5 different facilities. That's really helpful for you, right? You don't have to keep leaving my practice to go to another practice, and finally come full circle to me. So 6 months later, you can complete a procedure that we started way back in December. That's a major benefit. The flip side, again, in dentistry is this. If I'm a general practitioner and I'm doing lots of procedures, it would be like your cardiac surgeon trying to be your OBGYN. Not a place you want to be. So you have to be really cautious and understand what your dental health care team, what they're qualified to do, and what maybe you need to leave those doors and go to another place. So ask great questions. Find out what kind of education I have as a general practitioner. If I haven't done a root canal on you in 20 years, do you want to be my first one in 20? No, right. So be careful, ask great questions. And I'll leave you with one funny story here. This is, I don't know if this is perfect or just the antithesis of perfect for this room. Does anybody in this room know what that is? Sir, what is that? What would you call that thing on the screen? No. What's the image? Anybody? Poop. Okay. So my mom is a fellow boomer to all of you. My wife speaks and is also a video blogger. So she's like a tech junkie. This is what she does. Now, my wife's also an awesome wife and a great daughter-in-law. So I want you to picture this because this sort of wraps up the story of generations for us. It's National Coffee Day because you know Hallmark's created a day for us to buy cards every day. So my wife Anastasia sends my mom a text. And she says, Mark, happy National Coffee Day. I hope you have a wonderful day. And then for those of you who text message, she has those 2 little coffee cups. Have you ever seen them? And they clink together. And that's her sign off. My mom, being the wonderful mother-in-law, says, hey, Anastasia, thank you so much. Happy National Coffee Day to you. I hope you have a wonderful day. Yeah. So now you have to understand that for a long time, my mother, 2 things. I'm the Italian son and the oldest. So that has been a blessing my whole life, right, Gerald? When you're the oldest as an Italian kid and you're the boy, like you could do no wrong. But the problem is also you're responsible for taking care of all the messes. So I went to my practice the next day and I asked a room full of ladies on our team, there's 15 of us total, how many of you have ever gotten a text message from my mom? How many of you have ever gotten poop from my mom? It's a simple moral, right? My mom's a baby boomer. She thought she was doing something really great. Anastasia is a Gen X. She thought she was doing something really great. But there can be a real simple disconnect with all of us in this room simply based on our age and the way we communicate with one another. So you are going to be faced with the next 10, 15, 20, 30 years of your life working with physicians, dentists, hygienists, assistants, nurses, etc., who are a gap of a generation different than you. You have to ask great questions. You have to be an advocate for yourself, because sometimes, really inadvertently, we're going to think we're doing the right thing, or we're going to give you poop. Thanks for listening.
Thanks, Dave. We're going to, my brother Mike and I are going to grab some mics, and we're going to do a Q&A in about 1 or 2 minutes as soon as we get them all set up. So enjoy the meal for a moment.
That was good.
Thank you, though.
Now I'm fearful. I might fall off the riser.
So are you guys taking seriously about GPPC, or are you...
I just met with them again Friday, and they're supposed to be putting together some kind of an offer, and maybe we can get it 2 weeks. There are a couple of things that are issues, but things to be worked out. One is, I've been electronic, everything is in they're on. If it switches over to Cerner, that's going to be an issue unless Cerner can extract things from MedNet, because I can't go to a new medical record with losing all my data and just a bunch of PDFs. It's impossible to work. So
all of GPPC were at the same.
Right, because pretty much everyone is doing the same thing. So that's an issue. The other thing is, right now I go to independent health, primary connection, and Catholic clinical. So a lot of performance problems comes from those 2 groups.
Okay.
I think if I move, that I have to switch over to OPA, and then you can't be part of Catholic Medical Partners in OPA, and I'm not really sure about primary connection there. So there's a lot of revenue that's changing. How that's going to affect?
I think we've solved the primary connection.
Okay, everybody.
The OPA piece
Raise a hand. Who's been to 3 or more of our events here? All right, a lot of repeat customers. That's what we like. So what we're going to do is we're going to do a question and answer. with my brother Mike with a cordless mic and myself over here. And then naturally we'll break into a little prize scenario and then finish it off with a few more questions and answers. But I'm going to start. I'm going to ask a question to Dave Hughes from Kaleida. I was on your website today, and I noticed that you had waiting time for the emergency room. Now, you used to run an emergency room, or more than one. How accurate is a wait room time online for an emergency room, and what does that mean? Does that mean that somebody's going to take my name in 15 minutes, or I'm going to be diagnosed?
I don't know. Is this on? Can you hear me? Yeah. So it's a great concept, and it's been done all across the country. If you've driven across the country, you'll see billboards with waiting times. What that is it's supposed to represent, and I think it pretty accurately does, represents time to see a provider in the emergency room. So time for a physician or a physician assistant to see you in the emergency department.
So if it says 11 minutes, that means by the time you walk in the door, or is that after you've already given them 5 minutes of Q&A?
That's after you walk in the door, you're seeing a provider 11 minutes.
Okay.
That's supposed to be what it represents.
But I didn't know it even existed until I went on the website, so people should know if they have to go into an emergency room, pick and choose. But
you can get the app, Joe. It's on the app on the phone.
I'm older than you. I don't know if I've got that. Thank you. Any questions over here?
I have a question. Hi, a question for Dr. Norman.
Yes.
Can you talk a little bit about the impact of the patient portal? And for Dr. Rice, a question for you. Do you see dentistry going with the patient portal at all?
So what a patient portal is, for those of you who don't know, when someone comes in the office, we will ask for an email address and if they want to be in our portal. Portal is, we have a website, and on that website we have some basic medical information. There are ways that they can contact a provider directly. They can email me, they can text me, but it's a way for them to interact with the practice and the physicians without having to make a phone call or come into the office. So we actually have on there a disclaimer saying, please don't use this for emergencies or anything that requires an answer within 24 hours. But if you need a refill on medication, if you want to schedule an appointment, change an appointment, or if you have a medical question, we can answer those on the portal. So I think what that's done is it's cut down on our phone volume a lot. It's made ease of those things that I said, asking simple medical questions, or somebody who's taking their blood pressure at home and wants to send us blood pressure readings, or if they're testing their sugars at home, then we can change their meds. It's a much easier and more convenient way for patients to do that. We're trying to expand that and make it more real-time. So one of the things that we're doing in addition to care management and social workers is trying to get real-time visits via the portal or via some other, like a FaceTime mechanism, so that patients don't really have to come in the office. I mean, it's not a great way to look at a rash, but for a lot of things that you can either talk about quickly or converse on an email, it's very helpful, and I think it's opened things up a lot for patients.
So I think it will come to dentistry, but it will happen more slowly. We definitely, as a profession, lag behind medicine on the systems side, which is definitely a fault on the dental side. It needs to happen more frequently. I think I think you're alluding a little bit to the concept of telemedicine. Mm-hmm. So telemedicine and teledentistry, with our ability to communicate back and forth, I think the teledental side will come more quickly than the true portal side, where every patient interacts back and forth like you're accustomed to doing on the medical side. So it'll get there, but realistically, 7 years.
Yeah. And let me also say this, between David Rice and Alan Norman's offices, these two guys are good, all right? They are exceptionally good. They both spend a ton of money on technology, and you are accepting new patients. Yeah, a little self-promotion. Yes. No, I've been impressed with both their offices from a technology standpoint since the first time I walked in there, and that's important. What kind of a physician? If you have a physician or a dentist, that's aging out and is not spending money on technology and not, bringing in new staff, younger staff, doing more things, those are questions you've got to ask yourself also. Mike, you have any questions over there?
I've got one. Fast forward to February 2019, and I think I have the flu, and it's a Sunday. What is the best way to get this resolved? Do I go to the immediate care? Do I wait till Monday to go to the doctor's office? Or can I do a portal?
Well, that's what the portal really is for. So while I say don't use this for emergencies, between my computer and my phone, I get messages pretty much real time so that I can answer that and prescribe medicine over the phone. So what'll happen is I'll get a portal message or I'll get a message from my service. I'll either email back or call back and then send in medication. Now in New York State, you can no longer call in medication. You can't write paper prescriptions. Everything has to be sent electronically. So I do have to be someplace where I can send it from, but we do that. Go back to this February when the flu was out and it was pretty severe. And the recommendations were if somebody thinks they have the flu and you talk to them or you interact with them and you think they have a flu, don't bring them into the office. Don't send them to the ER because one, they're going to wait for a while, and two, they're going to infect everybody else around them. Start them on the medication that's appropriate, Tamiflu plus or minus anything else. Give them 24, 48 hours and then let them update you. So that's what we did this year. I don't think we saw 20 people in the office with the flu or who thought they had the flu because we tried to abort that by sending them, either via portal or telephone medication.
And I'll just comment on the payer side of that, and we talk about population health and the economics of healthcare. It used to be in the fee-for-service world that you would lose business by telling people not to come into your office, right, to be treated for the flu. When you flip the paradigm around and you start to pay on a per member per month for a patient panel size, changes that entire paradigm, changes his incentive to bring that person into the office when he could do it over the phone.
Exactly. Patty?
I just wondered, is anybody doing virtual office visits where you can talk in real time with your doctor, or if you have the rash, if he can see you, like Skype or...
There is telemedicine that is starting up in the area now. So I think that through the Blues and some other insurers, they actually have telemedicine sites. So you can do it via computer and or phone. It has its limitations. The problem is that in general, you're not speaking to your own primary care doc. So there's someone, you're trying to give an entire scenario of what's going on with you now plus history, and then they're going to prescribe medicine for you. I don't know how good that is. Yes, it's there and you can do it. We're working now to get that type of a system set up on portals for private docs. So I think that probably in the next couple of years you will see more of that. And again, what Dave said, we don't need to see people in the office to collect a fee just to treat them. It's better for us to take care of it when it happens, where it happens, and not have you come in the office. Not that we don't want to, but there's no reason to do that.
Dr. Norman, you're my primary, and I was curious about, years ago we had photographs taken in the office, and I wondered if that was mandated by the insurance company or for what purpose were those photographs taken?
So one of the things that the law has now said, part of HIPAA, is that we have to positively identify patients when we see them in the office. So you should always be asked to present photo ID when you go to a doctor's office. In most places you will. By taking a photo, we obviously have at some point seen some kind of an ID, or we know who you are. Now we've got the photo, so whether it's me or a secretary, or now the other doc in my office, which is my son, can identify that. The other thing is, I'm really bad with names and faces, so that if I'm looking at my computer and somebody says Mrs. Jones, and I'm like, I know the face for sure, but so when I bring it up, then it's recognition for me. So some of that is my deficit. But it is mandated by law. You do have to have photo ID, and it prevents people from asking you for photo ID every time you come in.
That's great. This is part two, and anyone, dentist, medical, stem cell research. You know, my doctor says I have to have shoulder replacement, and I say, I'm going to wait, because with all the stem cell research, maybe at some point in time I'll grow new muscles, tendons, whatever. How close are we to growing new teeth or having bones and muscles and things reproduce with that type of treatment?
A lot closer than you would think. So while you can't go out and have somebody grow you a shoulder,
I wish.
There are now places where they are actually cultivating cartilage and joint replacement tissue and other tissues for things that will come out like heart valves or other type of replacement. My daughter just had a baby, and one of the things they asked her was, do you want to store cord blood, which is basically stem cell blood, in case the baby has a problem at some point and stem cells have progressed to that point that she has her own stem cells. So I don't know if you should be waiting for the shoulder, but it's out there and it is actually being used. So we are growing tissues. We're growing skin. We're growing some joint replacement tissue. There's I had knee surgery a few years ago, and one of my options was to fly out to one of the guys in Denver who was working on a lot of the skiers, and instead of doing a knee replacement or cartilage replacement, what they were going in and doing is tapping into your marrow. So they go in with an arthroscope, tap into your marrow, and let your own marrow cells come out and just sit on the top of the cartilage, and your own marrow cells, some of them being stem cells, would form they'd become cartilaginous forming cells, and they would regenerate your cartilage.
On the dental side, I would say within 5 years, we'll be regrowing teeth. Research-wise, it's been happening for 2 years already. It's really cool. So it's very simple. So you've probably heard of 3D printing. So you 3D print a framework, and then the stem cells go within that framework, and they know what to do. It's really cool. So if you have grandkids or super young kids, and the oral surgeon wants to take their wisdom teeth out, that's a good source for those cells.
To add to that, only in the last 24 hours, I read an article of a gal who lost an ear. They took her cartilage, put it in her arm, regrew the ear, attached it, and she's almost ready to hear at this point. So the technology is really impressive. Next question.
I have a dentist question. With the advent of these tooth implants, are the root canals going to be a thing of the past? That was before I found out I could grow new teeth.
Good. That's a great question. So if you think of a dental implant, it's just a man-made version of what Mother Nature gave you. So it's a man-made root. So what I would share with you is, if you have a great tooth and a skilled provider who can do a great root canal without doing multiple other procedures as well, then I would keep the tooth and do the root canal, because it's very predictable to do. If you have a complex case, then taking it out and having a dental implant placed today is absolutely a tremendous move to make.
All right, next question.
I was wondering what makes the new shingles vaccine so expensive. I've seen people told they have a $150 deductible to receive the vaccine, and they walked away because they didn't want to pay that amount of money. What makes it so expensive?
Like everything else that's new, and the drug companies have to make up the money that they spent in research, that goes for vaccines too. So anything you see advertised on TV, any of the new diabetic medicines, any of the medicines for psoriasis, I mean, any of those things are incredibly expensive. I look at these meds and I'm appalled sometimes at the prices. So I'll write prescriptions for something and then I'll look at the price and like, oh my God, that's just crazy. As far as the vaccines, there's a lot that goes into vaccine development, and vaccines have limited shelf life, so that makes them a little bit more expensive. But again, anything that's new, think about the drug companies, the pharmaceutical companies having to make up all their research and development investment. That's why they're so expensive.
This is another dental question for someone here. A crown to be replaced, who's the best practitioner to go to? One of the big offices, a solo practitioner, or one of the offices that have those machines that can crank it out right away?
Okay, let's do this in the politically correct fashion. The quality of a crown or anything else, and apply this to medicine, is entirely based on the quality of the operator. Now, you're going to have tremendous operators. As a solo practitioner, you'll have tremendous ones in small groups, and I'm not going to stand up here and tell you that you're not going to find one in one of those big, giant groups. I will share with you that statistically speaking, with the turnover rate that are in those big groups, and multiple other factors that I will happily have one-on-one with you, that may not be your best option to go there. That's just the truth.
We have 3 hospital systems in Western New York. Do you think they'll ever actually work together?
I'll answer that.
Okay.
So we have worked together, and I'm not sure what 3 systems you're referring to. The Erie County Medical Center and Kaleida Health are really under one roof, which is Great Lakes Health. Roswell Park is standalone. Kaleida, for instance, has partnered with Roswell Park on pediatric cancer care. One of our floors in the new Oshai Children's Hospital is actually a partnership between Roswell and Kaleida. The Catholic Health System in Buffalo, New York, and up into Niagara County, we've worked together on a joint cath lab up in Niagara Falls. There is certainly a healthy amount of competition locally, and I think that's probably a good thing. If you look at where our insurers are locally, the cost of health care in Buffalo is relatively low as compared with across the country, and I think some of that competition is probably driving that. I think I'll say one other thing about cooperation and doing things together. One of the things that has come out of as we've seen healthcare over time, and it's been alluded to a couple of times here tonight, is that the more you do, the better you'll get, and the better quality you're going to get. So when you have a stroke center like the GVI, which is the busiest stroke center in New York State, doing advanced stroke treatment, it's tough to start to spread that care out. It should be centralized. There's certain care that should be centralized so that you have the fewest people doing the largest volume, because that's how you become an expert. That's how you get good at it. So there is cooperation. There's a fair amount of competition as well, but it's a good question.
All right, I've got a question over here.
Could you tell me the difference between a PA and a doctor?
A physician. Yeah, you want to go ahead? Yeah.
Sure. So you've got 3 practitioners that you may see if you go into a physician's office or a hospital. You can see a physician, you can see a physician's assistant, or you can see a nurse practitioner. In order of the hierarchy of those 3, physician is the highest, then comes nurse practitioner. Nurse practitioners are RNs who have done a master's in a practitioner's field. They can practice independently. They have their own license. They have their own narcotics number, and they can practice without a physician being present or without a supervising physician. A physician's assistant is one step below that. They are licensed, but they don't have their own ability to write prescriptions or narcotics without a physician on premises, nor can they work without a physician on premises. So really, while some of them act as independent practitioners, they're always under the direct supervision of a physician, whereas a nurse practitioner is not. As far as schooling, a physician goes to 4 years of undergraduate college, 4 years of medical school, and then depending upon specialty, does specialty training ranging from 3 years for family practice, internal medicine, 4 years for obstetrics gynecology, 5 years for general surgery, 7 years for neurosurgery. That's graduate training. Nurse practitioner, as I said, does a 4-year RN study and then 2 years of master's for a practitioner. PA school, depending upon where you go, can be either 4 or 5 years or a 2-year program after some other degree. As far as who's better, depends on the individual practitioner. There are some PAs who are just great and who work in emergency rooms and can do exactly the same thing as the physicians can to a limited extent. There are some NPs who work in the same environment or in doctors' offices who also can do pretty much the same thing. I'm lucky enough to have a nurse practitioner who's been with me for 15 years, and she's great. I mean, we talk about all the things we do, we talk about the patients, but she's an excellent practitioner, and I trust her to take care of me, so I think that's a statement.
And our final question.
I know that they have medical marijuana is okay in Seattle and other places out west. How do you feel about it coming here? Do you feel it has enough merits?
And that's my mother-in-law asking about joints.
It's already here. You can already get cannabis derivatives here. There's a difference in what is medical marijuana, where you're taking marijuana buds and leaves and you're smoking those, as opposed to the extracted oils in tablet or capsule or some other form that people are using for very specific disease treatments. My own personal opinion is whatever works is okay. I have had patients who have had different types of cancers, and I can think of one in particular, and his wife was a nurse, and she said, "What do you think about medical marijuana?" I said, "Well, you're not going to get it here in this state because it was a couple of years ago for what you've got, but it's great for nausea, it's great for pain relief, it's great for anxiety. So find a kid on the street, get some, try it, and if it works, keep the seeds and grow your own." And she, and she did, and she grew them in a pot in her backyard, and she grew one plant, and nobody ever bothered her, and it works really well for some things. Now, it's not a cure-all, but it does have some place in treating nausea, appetite stimulation, treating pain. I know they're using it now for seizure disorders. There are a lot of things it's being used for. That's not the kind you smoke. That's much more a very measured dose form, individual appropriate type thing.
Okay, now we're going to break into a little fun that we always do, where my brother and I'm going to ask 3 different questions, and the winner amongst this audience of 250 people gets a Georgetown cooler, and as you know, these are the greatest things out there, especially going into the summer months. So we've got 3 questions. I'm going to start with a little setup for it, but David Hughes, how many employees are there at Kaleida?
About 9,500.
Okay, so here's the question to the audience. How many job openings on your website are there at Kaleida right now? Shout out any answers to my brother Mike or me.
300.
Mike, you got anybody close?
Nobody's close. What? Starts with a 4.
40?
It's going to be a rumble.
I'm dying to know, Joe. How
All right,
many?
it's 486. All right.
Wow.
We had a 400 over here, so we got 486 job openings.
I got the winner right here,
Oh,
though.
you do? All right. Okay. All right, Mike, go get another one out there because I just gave one. So now we got a couple more to give out. All right. The next question. I told you guys this is going to be fun. It's a derivative of a dentistry question. Everybody's gotten bitten by a mosquito over the years, and you really didn't know you were bitten until hours later and your arm swelled up. How many teeth does a mosquito have? Shout out some answers.
Thank you.
Come on. You got skip. Shout More.
No.
Oh, come on.
Whoa, I got a winner.
All right.
Somebody's got to
47. This has been double
Right
checked.
on the number.
It's double checked by the anals of Google. So next time you have a mosquito bite, you're going to say to yourself you had 47 little perforations in your arm, leg. See, we make this fun, don't we? All right. Now the last question is something near and dear to my heart. How many dollars has the Ride for Roswell raised aggregately in the last 22 years? And we're talking millions. Shout out a number.
You already won. What was that?
45. Probably about 2 million a year.
67. Yeah, it's got.
He said he did 100.
$44 million.
Somebody looked on.
40 million.
On the bottom of my heart, I want to thank David Rice, Alan Norman, David Hughes. When we put this event together, we knew it was going to be great. You brought some great value. This is what you do for a living, but to us, you should know that what you take for granted, we really are in awe over. Things that are going on in the medical field that David Hughes can go, look at surgeries that are going on live, and there's 5,000 people looking at it across the country, and these aren't schleps that are looking at it. They're pros. That's very, very impressive. For Alan Norman, and David Rice to be able to hear, these are patients or relatives of patients. This is what we're thinking, so it's good interaction for you to know what's going on out in the street, out in the world. But I want to thank everybody. I had a great time. I listened to this great. I felt wonderful that we were able to put this on. Mike, do you have anything to add?
Just thank you guys very much. This worked out perfect.
Yes, this worked out great. And if you're going to ride in the Ride for Roswell, join Kids Just Want to Have Fun. Thank you very much. You guys want some dinners to take home? Because I know they always make extra.
Thank you.
We're all going to head to the bar. Another exercise. And he's a sniper also.
Really?
That's my other job. I work for a police department in the last 15 years.
That's amazing.
They still doing it? Yeah. Really? That's awesome. Only because they give me a get out of jail free card.
That's awesome.
I'm gonna put my picture.
Didn't we make those in somebody's basement or something?
No.